The Sinistral Surgeon, How to Teach the Left-Hand Dominant Gynecology Training. We have no disclosures. Right lateral bias exists everywhere, from can openers and spiral notebooks to the location of water fountain handles and the French word gauche, which not only means left, but also awkward, clumsy, and socially unrefined. The list of indignities is long and extends to the surgical profession. Handedness is a faster or more precise performance or individual preference for use of a hand. Handedness is not a discrete variable right or left, but a continuous one that can be expressed at levels between strong left and strong right. There are several types of handedness: left-handedness, right-handedness, and ambidexterity. 11% of Americans, 20% of men, and 8% of women are left-handed. Studies reflect similar percentages of left-handers among medical personnel. Left-handedness has been considered a simple inconvenience by some, whereas left-handed gynecologists feel that they are the, quote, last unorganized minority, unquote. Left-handed tennis players or baseball batters have little problem. The tennis racket and baseball bat are the same on both sides, and the tennis court and baseball diamond are symmetric. The difficulty of the left-handed surgeon using right-handed instruments is akin to the left-handed golfer using right-handed clubs. Notwithstanding instruments, right-handed bias begins even before starting a case, as most surgeons glove right-handed first. An exception is the Mayo Clinic, where surgeons glove left-handed first in homage to the left-handed Mayo brothers. Given the demand for surgical dexterity in the midline, bilaterally, and lateralized procedures, it is important to assess the attention given to left-handed trainees and the adaptations adopted by experienced surgeons. Studies examining left-handed surgical performance come primarily from the general and orthopedic literature, which have demonstrated that novice right-handed surgeons possess a greater degree of ambidexterity. Left-handed operators perform endoscopic tasks more slowly, but with the same precision as right-handed individuals. And left-handed dominant general surgeons perform better on tests of tactile spatial abilities, but are rated worse by supervising physicians. The novice left-handed trainee is faced not only with learning the complex motor skills of gynecologic surgery, but also with the fact that dissection must be performed with her or his non-dominant hand. The purpose of this video is to demonstrate how to avoid the 7 most common difficulties when training the left-handed trainee. There are 7 major issues for left-handed surgeons. 1. Anxiety about laterality. 2. Lack of mentoring on lateral preference. 3. Difficulty handling traditional instruments. 4. Difficulty with minimally invasive instruments. 5. Inconvenience for other surgical team members. 6. Pressure to change lateral preference. And 7. Possible disadvantages with certain procedures. Number 1. Anxiety about laterality. There are a number of ways that a left-handed surgeon can overcome a right-handed bias. The most obvious and common technique is simply to adapt and to adjust, often through personal experience of trial and error. The presence of many excellent left-handed surgeons in the audience today is a testament to how this bias can be surmounted. Ideally, the bias can be resolved by creating a left-handed friendly environment through early laterality-related training and medical education. In addition to difficulty with instruments, left-handed surgeons usually must learn operations as they are approached by right-handers, an approach that can be difficult without considerable translation. Difficulty handling traditional instruments. For maximum cutting efficiency, scissors are designed so that your natural grip will force the blades together to improve cutting. Note the left shank of the scissor overlaps the right, which makes it easier to view and to handle for left-handers. Left-handed scissors have the blades reversed, so the top blade is always on the left. This gives the surgeon a clear view of the cutting line and allows the scissors to cut properly when held in the left hand. Ordinarily, left-handed surgeons must reverse the usual motion to open right-handed needle holders, hemostats, and other locking instruments. Alternatively, the left-handed surgeon must learn to use these locking instruments with the right hand. Both methods are fatiguing and unnatural for left-handed surgeons. For needle holders and hemostatic forceps, the ratchet mechanism is on the right shank instead of on the left shank. The left-hander may partially overcome the difficulties with instruments by obtaining left-handed instruments. According to the survey by Adesumili et al., a majority of residency programs do not offer left-handed instruments. Not only are left-handed instruments more expensive, they are also difficult to find. We have purchased a left-handed set of Metzenbaums, Mayos, and Haney's that cost close to $500. Most commonly, left-handed gynecologists position themselves in equipment on the patient's left side, as well as recording handedness on a preference card or reminding operating room staff of their left-handedness. It is interesting to note that laterality preference of the left-handed surgeon is noted only 35% of the time on the operating room preference card. Simple documentation of the surgeon's laterality preference might eliminate the interpersonal conflicts and inconveniences between surgeons and operating room staff that promotes a congenial operating room environment. The approach to operations can be handled by attempting mirror imaging of the right-handed approach, which may involve doing some abdominal and laparoscopic operations from the left side of the patient. We recommend to allow left-handed surgeons to stand on the right side of the operating room table. Left-handed surgeons felt that the following surgical procedures are difficult to learn standing on the right side of the operating room table: abdominal hysterectomy, total laparoscopic hysterectomy, and right ovarian cystectomy. Left-handed surgical residents should be given a chance to stand on the left side of the operating room patient. Left-handed surgical residents should be given a chance to stand on the left side of the operating table, which is quote-unquote right for them to learn. Left-handed surgeons are more prone to needle sticks than their right-handed colleagues. Pressure to change laterality. Another less successful approach is to switch over to the non-dominant hand until a level of dextral control similar to that shown by natural right-handers is achieved. We encourage our residents to brush their teeth, eat their food, and practice surgery with their non-dominant hand so that they are not a, quote, one-handed wonder in the operating room. The most comprehensive adaptation is to become right-handed as well as left-handed. The left-hander who becomes ambidextrous not only has added versatility, but is likely to gain insight into surgical technique that a right-hand. The left-hander who becomes ambidextrous not only has added versatility, but is likely to gain insight into surgical technique that a right-hander may never have. However, studies by Bryden et al. Demonstrated that as the complexity of the motor task increases, the time to equate the performance of both dominant and non-dominant hands also increases. Given the limited time and faculty available associated with current surgical training curricula, failure is likely if the switchover occurs later in life in someone who is not sufficiently ambidextrous. In conclusion, left-handed left-handed individuals comprise a minority of gynecologic surgeons and trainees. Though many such individuals develop varying degrees of ambidexterity with experience, preferential use of their non-dominant hand is inevitable. Despite the hands-on nature of the gynecologist practice, both in and out of the OR, tailored instructions for those with left hand dominance is uncommon. Consequences, if any, of this missing training are unknown, as left-handed gynecologists seem to adapt to environments Consequences, if any, of this missing training are unknown, as left-handed gynecologists seem to adapt to environments biased to the right-handed surgeon. Further comparative studies are necessary to determine differences in performance, skill, and outcome that may exist between left-handed gynecologists and their right-handed counterparts.